Hello, listeners. Welcome to Views on Health. Back with us on the program tonight is Dr. Pravin Wijesinghe, consultant plastic surgeon, teaching hospital in Batticalow. Having come to Colombo all the way from the Eastern Province, we truly appreciate your time and input, Doctor, to the series of programs. And for the information of our listeners, Dr. Pravin Wijesinghe is going to speak on congenital hand deformities. I assume it's another common problem that you come across in your practice. So without any further ado, Doctor, the microphone is yours.
Thank you, Fatima. Yes, so this is again one of those unique topics which is not spoken of too often. Why I thought I should talk about this is because it's not uncommon. It's the statistics suggest that we see a congenital hand disability or deformity in 20 children for every 10,000 live births, and that's not a small number. It's a devastating problem for new parents, and they will have many questions. Sometimes they think there are no options, and what I need to tell them at the beginning is there are options for almost every condition that comes under congenital hand disorders. Why I thought this should be informed is that some of these conditions are time sensitive. They need to be done during a particular period in their life. Like for instance, if the fingers are conjoined or if there's a double thumb, those need to be sorted before the child goes to school, because otherwise they're going to have issues, social issues in school. So they generally occur isolated. You may not have anyone in the family with such a problem, but this baby might be the first baby that's presenting with such a problem. But they can be part of a condition where the mother or the father or a grandfather might have had a history of something. May not be the same condition, but may be something different, but in the hand. So they can come down. They can follow a lineage sort of thing. Generally, it involves the hand only. It's isolated to the upper limb, but it can be part of a syndrome where a kidney or the palate or the heart, there might be a heart disability which is congenital. If you go through the classification, it's a complex classification. I'm not going to talk about that classification. It's too complex sometimes for us to understand. So I'm going to simplify it. If talking about the thumb might be positioned differently. The thumb should move out from the plane of the fingers and then reach out to grab things. But the thumb might be stuck in the palm, which is called a clasp thumb, and that might be it's actually a complicated condition where the thumb is stuck in the palm. The thumb might be stuck in a flexed position. Thumb needs to be moving, the joint needs to be moving up and down, but it might be stuck in a flexed position, which is called a congenital trigger, which is actually a misnomer, but anyway, for all practical purposes, they present soon after birth. The thumb might be absent. You can imagine, we have 8 grips as far as clinicians are concerned. We have 8 grips in the hand. Of that, 6 grips involve the thumb. We are human because of an opposable thumb. An absent thumb or a hypoplastic, which is a deficient thumb, will affect everything we do. And so that's called a hypoplastic thumb, which is actually more common than you think. It could be deviated. It could be deviated up and down, or it could be deviated from side to side. And another common condition is duplicated thumb. There are 2 thumbs in the space of one. If you move on to the fingers, they can be joined together, which is called syndactyly. And they could be involving 2 fingers, 3 fingers, all the fingers. They could be isolated just to the hand, or it could be involving the toes and having other disabilities in the body. There could be short fingers, which are called brachydactyly. There could be deviated fingers from side to side, clinodactylies, and it could be missing completely with a big cleft in the middle. Unfortunately, these clefting hands were called crab hands or claw hands once upon a time, which is, I think, a terrible name for it, but that's what it was called. All the fingers might be absent congenital. They are born without a single finger. That could be part of a syndrome, or could be isolated. They could have an extra digit on the medial part of the hand, not on the side of the thumb, but on the other side, which are called ulnar polydactylies. The fingers might be double the size, which are called macrodactyly. They are big sized fingers, which are obviously going to come in the way of normal function. Moving up the upper limb, there are two bones, the radius and the ulna. There are just two bones, one on the outside, one on the inside of the forearm. Both those bones can be deformed, causing various disabilities in the limb. What we need to realize is as I said initially, they can be isolated, but they can also be part of a big syndrome. They can have kidney issues, and the hand problem might be the key to diagnosing all that. So you can imagine a child born with a disability coming up with all these. A lot of parents, it's overwhelming for them. They wouldn't know what to do, what can be done, or can anything be done in the first place. So again, as with anything, refer early. We will guide them. Sometimes they're born without a hand, and that's probably the only condition where we say there is no surgical option for them. But again, we can guide them through prosthetics, which are going to come later down the line, but they'll be prepared for it. We can refer them to support groups. There will be similar affiliated families which they can talk to. So these things are really, really, really important. Very, very rarely, congenital hand deformities come at a much later stage when they're adults, when they're about to go for an interview or they're about to join the army. They would say, oh, look, you got a problem, can that be sorted? I got a patient recently who had a bifid thumb. The thumb was duplicated, and he was just about to join the army, and they said, look, can you sort this out before you come to the army? You can do some of those surgeries at that time, but it's better done when they're younger, when they do not know what has happened to them before they go to school. We have a very cruel schooling system sometimes. People get bugged all the time for much simpler things. If you have a cleft in your hand, your hand looks like it's a crab claw, or you've got the fingers stuck together, or you've got a thumb that looks duplicated. You're invariably going to get bothered. So for parents, one of the commonest questions I get from parents is, look, doctor, I've had this problem. I've lived with this. Does my child need it? And my answer to them is always yes. And it may not be functional. If the parent lived with it, the child definitely can live with it. Then their function may be normal. But what they don't realize is they've forgotten the psychological trauma they went through when they were in school. So my answer to them is yes, before the surgery should also be done before school age.
Thank you, doctor. So this is a case where you might see it in the parents and then in the children. So it's in the genes, I guess, that brings about this condition. Is it possible to explain that side of it?
Yes. So most of these conditions are point mutations, in the sense you are the first presenting patient. You've never had this in the past in your family, and you're the first patient to get it. But once you've got it, there's a slightly more risk of you transmitting it into your children. So the patient's children, or down the line, will have a slightly more risk. There are conditions which are autosomal dominant, which basically means you got a 50% chance of it getting transmitted to your offspring. So if your parents had it, there's a high chance that you've got it. And if you've got it, there's a high chance that your kids will get it. But in most scenarios, there's no history in the family. It has not come from anyone. It's just that you are the first person to get it.
In that situation, what happens?
So nothing. We just advise to the fact that your kids can, obviously the child's kids, which is down the line, can get it, and we proceed with the treatment. There's no gene therapy, or there's no treatment in the sense there's no special tablet that you can take to prevent it, because it's already happened. Now what we can do is get them back to normal function. That's important, but also to make it look as normal as it could. And there's a lot of options out there for all those conditions that I just mentioned.
So obviously it involves surgery.
More often than not, yes.
So could you elaborate?
Yes. So let's talk about a common scenario. If you have a thumb that is duplicated, you have two thumbs instead of one, we can remove the extra thumb. We need to decide which one. The one that looks more normal than the other should be kept, and the one that is more normal should be removed. It's not just about chopping it off. It's about bringing the thumb into alignment. A thumb should look like a thumb. Thumb can't look like a crooked thumb at the end of the surgery. So it's not just let's just chop it off. It's about finding certain structures that are in the removed thumb so that those can be transferred to the newly created thumb to bring about function. So these are not simple surgeries as such. It's generally complex. If you're born without a thumb, we do a very interesting surgery which is called polyzization. In fact, there are a lot of kids out there, or moms out there, who got kids with either poorly formed thumb. There is a thumb, that thumb doesn't move like a thumb should, or they don't have a thumb at all. So what we do is we take the index finger, we use the index finger, we don't cut it and remove it, but what we do is we do procedures so that the index finger is now going to look like a new thumb. Now, this is a very difficult scenario for the patients, because what they from their end, it's, you're going to remove one finger to create a thumb. But from my end, you're gaining a thumb which is more than 80% of function in that hand. And I'm going to tell you that it looks so nice with the thumb, even after removing that index finger to create the new thumb. It looks so normal that sometimes we forget that there is one digit missing in that hand. True, we lost an index finger, but you got a much more functional thumb. Sometimes kids are born with a thumb, but there's no other finger. Although the thumb is the most important digit in the hand, without anything to oppose against, thumb is just, it's good for twiddling. That's all. That's about it. There's nothing you can do with it. So you need a post on the opposite side of the hand to oppose against. So when there are kids born without any other fingers, what we do is we take a toe. We microsurgically transplant the toe onto the hand, and they can grip. They can do a lot of things. They can play. They can throw a ball, which is totally non-existent in that hand before we did that surgery. That's to do with the thumb. When it's syndactyly, which is one of the commonest scenarios, syndactyly means your two fingers are stuck together. Now these syndactylies can be simple, in the sense there's nothing else but the skin attaching them together. But it can be complex too, where there are bony issues, cartilage problems, not enough skin, or one is short, they're sharing a bone sort of thing. Either way, the surgery will make them two separate fingers, and they look pretty good. They look nearly normal. Of course, there will be a bit of scarring because we made a cut to create that separation. So we do syndactyl separations. In children that's having a missing middle finger with a big cleft in the hand, which is called a cleft hand, these clefts can be reduced so that they look like normal hands from far. Even when they're working close by, if the surgery is done well, sometimes you can't even say that they've got a missing finger because you don't notice that. They look normal from afar, and that's what we try to. So we try to achieve good function. We also try to give them normal looking hand. When a finger is big, it's so huge. It's 10 times the size of a normal finger. That's called macrodactyly. We reduce the finger. we try to reduce the finger to sort of be in relation to the other fingers to be a normal size. But sometimes these fingers need removal. The way why we do remove them is because it comes in the way otherwise. And so although an amputation sounds like a drastic procedure, for that patient, that's a life-changing procedure where they go back to near normal function. When they are born with an extra digit on the inner side of the hand, you can just take it off and they look normal. These, in Sri Lanka, a lot of people think these digits bring about luck. So they are very, they don't want to remove them. I don't think they bring about luck. They are not rabbit's feet. I don't think rabbit's feet bring about luck either. But these should be removed. They should be done before the child hits school, because they will get bugged. There will be people trying to pinch that. There will be people mocking them about that extra digit. There are some conditions that require early treatment. Generally, we operate on children at the age of 1. That's because of anesthesia. We don't want them, unless they really need the surgery. We want to push it off till year 1. But then there are some conditions that need treatment before that. Things like, there's a condition called club hand. It's a bad name for what basically is the bone radius is shorter on that side. So it bends into the form of a club. Now those children need splinting, which is nothing. It's just a simple thing done by the occupational therapist, where they take a piece of plastic and they continue to, because children's bone, the newborns' bones are malleable. They can be straightened. I mean, of course, within limits. They can be straightened and they grow into a straightened form. So that needs to be done as soon as they're born. You can't wait for 2 years when bones are much harder. At that point, you need to operate and cut and chop to sort of get them straight. So if they come early, we can just put a splint. That's all they need. Then there are kids that are having inward curved fingers. Those are also children that they're called arthrogryphosis or clinodactylies. They can also be corrected just by splinting. You don't need anything else. So you can totally avoid surgery at times. But beyond a certain limit, they will need operative treatment.
So very interesting, doctor. And you find this fairly common in Sri Lanka, and you're dealing with it. Now, obviously, at first sight, it can be, you quite right to say, overwhelming for the parents and the other loved ones around that this baby has this condition. But then the fact is that the awareness is so important that they should know we can seek treatment and put it right, and soon, instead of waiting. Unfortunately, our country is full of myths, and that's something I think from time immemorial, and we see it being dispelled over a period of time, but it is still there, and not as rampant as it used to be, but they are enough to impact on the work that medical professionals do. It's in most ailments. They also believe in myths, and they delay treatment, or they go for different type of treatment, alternate types of treatment because of that. So they come back to you, and then there is an issue. It's kind of rather late in the day. But now, once these are put right, functions are normal according to the condition, as normal as can be, or fully normal.
So the functional restoration depends on what the child has had. Most of what I've just told you become functionally normal. Of course, because the kids have growing bones, they need to be followed up till puberty, because sometimes genetically, even in that deformed state, they're supposed to go in a certain way. We've just intervened. And down the line, some deviations can occur. So even after the first surgery, we generally get them down at 1 year. Then the next growth spurt is around 2 to 3 years. We get them down close to that day, because there can be certain deviations. Suddenly the mom or parents will be worried, oh, look, there's a bit of a bump here. And again, at the age of 12, 13, 14, when the puberty hits, the bones suddenly grow. And remember, the bones were supposed to go in a different, we've just intervened. and we need to reassess them at that point, just to say, look, okay, you may need surgery, may not need surgery, we're just following up. And it's always good to have that chat and that good rapport with the parents, because they will keep coming to you. And it's always nice to sort of follow them up, and to see them grow with this significant deformity that they were born with. But down the line, they look absolutely normal, except for a tiny scar.
So, doctor, now children who are born with this condition, do you see any similarities in case of such deformities on their toes?
Yes, so there are some conditions which involve all four limbs. There are things like, there's a condition called Apert syndrome, which is a condition that has very complex hand deformities, foot deformities, and also cranial deformities. They are absolutely normal children otherwise, but they look different. And in that scenario, in those scenarios, that's why I keep telling, as soon as you see a hand deformity, send it to us, because in that scenario, that's a condition where the cranial part of it, the surgery that requires you to sort of expand the skull, needs to be done before the age of 1. Otherwise, the child will have learning disabilities, intellectual problems. They need to be sorted early. We can sort the hands out after the age of one, but the cranial part of it needs to be done, because the head grows much quicker. At the age of 1, the head is actually bigger than the body, so they need to be sorted out early, and that is also done by plastic surgeons, a differently trained group of plastic surgeons called the craniofacial surgeons. But they need to be, so that might be the first referral point. You will come to see the hand, and we'll say, look, hand is good, we'll sort it out, but you need to sort the head out first, because we need to do this massive surgery to make sure that the head. So yes, so there you can find multiple disabilities, even in the heart. Sometimes the children, they come and show the hand is deformed, we can see that, but there's a chest deformity. And if in this, there's a condition called Polyzization syndrome, where the chest musculature is deficient. Now, if you're a male, it's just aesthetic. It's just a flat chest on that side, big on the other, normal on the other side, but a flat chest. But in a female child, the breast will also be affected. So these children need more surgery down the line, especially aesthetically. They will need to, because one breast will grow normally, but the other won't. So there will be a breast asymmetry that needs to be sorted out later down the line, obviously. But they need to be told that. They should not be a surprise at the age of 18. They should be told that at the age of 1, as soon as they're born, look, this is what you have. We can sort it out. But it's not just one surgery. We need to guide you through it.
So how receptive are parents to these conditions?
Depends. So some say, oh, I've been told that the extra digit is connected to the brain. Everything is connected to the brain. That should not be a deterrent to the surgery. Everything is connected to the brain. Some say, oh, I've been told the gem that I've just found is because of my child's extra digit. Highly unlikely. So some people will not listen, especially if they've had the deformity themselves and they've gone through life. Now they're at the age of 30, their child is having the same issue. I had a patient, very interesting story, where a patient came to me and said, look, doctor, my child is having a bifid thumb. My child has a double thumb. So I assessed and I said, look, this is what your child needs. It needs to be removed before the child is before the age of 1.5. He said, no, I'm not here to get it removed. I'm just here to show you that it's there. I said, what are you talking about? No, I've had this. I'm sure my child can live with that. So we had to take a lot of time and effort to just make sure that the parent is convinced enough to get that surgery done before the schooling age. I mean, Hrithik Roshan had it, right? Hrithik Roshan has lived with it. That doesn't mean your child should. It can be operated to look like a normal digit.
Interesting, Doctor. Thank you so much. So we have to obviously create the awareness amongst the parents that if your child has this condition, don't hesitate to get expert treatment for this particular condition to put things right. But like you said, if they have had it, then the chances of convincing them are far more difficult. But if they haven't, they obviously would want their child to be like them, back to normal.
Yeah. So although this is a congenital problem that starts from birth, there are adults out there who've never had the surgery, and they may or may not like what they have. Recently, I met a girl who's got a double thumb. So I approached her in one of the more popular shops in Colombo. And so I approached her and said, "Look, have you ever got an opinion about what you have?" What she said was, "When I was small, my mom did, and they said, look, there's nothing much we can do about it unless we remove it." And I don't blame the parents at all there, because maybe 20 years in the past, these options may not have been there, or not a lot of people knew about how to go about sorting these out. What she had was a complex one, but not anymore. So even these adults who have missed the bus, sort of thing, you've never missed the bus. We can sort it out. We can still make you look normal. We can still make it look, especially people going for interviews. I mean, they will look at those. People joining. I've heard that even these popular, famous grocery stores out there, in these supermarkets, when they're hiring, they look at these. So, I mean, if you think you've had it, this should not be a deterrent to not, stop your career halfway. You can still join the army. You can still join wherever you want to go. All you need is somebody who is skilled at assessing it and somebody who's skilled enough to do it.
Thank you, Doctor. So it's very, very interesting, and I think when they're adults and if they have the problem, you can still deal with it. And then they can take an informed choice. They can make an informed choice, actually, and go for it.
Yes, so why I said adults can also be operated is not to say don't come when you're a child. Do come when you're a child. Bring the child in. I'd rather operate on the child and sort his problem out when they are 1.5, when they don't know anything, and they can't remember anything, when they don't have the trauma of going through with that deformity to school. I'd rather do that than operate on that same patient when they're an adult. Especially when it comes to things like removing using the index finger to create a new thumb or a neo thumb, which is called a polyzization, especially things like that. It's so much better when it's done at a young age, because their brains train itself to basically become the thumb that they've never had. So, that surgery can also be done at an adult when they're an adult, but it's never as nice as when it's done when they are a kid.
And in any case, as a child, you grow with it, and then you get used to it.
It becomes the new normal. So start early, and there are some instances where if you miss that chance when you're a child to retrain that hand to make it look normal and function normal, needs a much bigger surgery than when it's done at a younger age, where we can use sometimes just simple splinting, and the results from the surgery will also be much better when they're done early rather than when they are beyond puberty. When the bones are fused, the bones are stronger, bones are not as malleable. Mind is also not as malleable as it is when you're younger.
Thank you, Doctor. On that note, we end this very interesting discussion on congenital hand deformities. Thank you so much to Dr. Pravin Wijesinghe, consultant plastic surgeon, Teaching Hospital Batticaloa, for being with us once again on the program and explain to our listeners how easy it is to get some deformity addressed at the very outset, as against putting it off for a later stage. Thank you, Doctor.
Thank you so much.
Thank you also to Vimukti Eroshan for technical assistance. I'm Fatima Razi Khader saying good night, and looking forward to your company next Monday, same time, on Views on Health.